Good morning, everyone. First of all, from the outset, I want to thank Professor S.K. sir and Professor Santu Pandey sir for giving this platform. And after the talk of artificial intelligence with such a nice discussion, this will be a little boring topic of drugs. For a surgeon, discussing drugs will be like, I need to be a little more interactive in my talk, I understand. So basically, translating evidence into practice with newer drugs, why we are discussing this. If we see 10 years back or 15 years back, whenever a heart failure patient comes to us, we always used to say the prognosis, what we used to learn at MBBS years, the mean survival is not more than 5 years, 6 years, because the drugs available to us was like within 5 to 8 years, the mortality is about 100%. But in past 10 years, we have seen there have been availability of newer drugs, which have really changed the scenario in the management of the heart failure. And heart failure per se is the most common entity, which is one of the most common entity, which is leading to your cardiovascular mortality and morbidity in our patients. So if we see the global burden of the heart failure, it is about the pandemic, which is happening all over the world. About 26 million people are affected and this expenditure of more than $31 billion worldwide. And if we see India is not say separate or different from the rest of the world, and we are having an increased risk for developing of the heart failure. They predicted, if we see that about there will be rise of 25% if we predict by 2030. The reason which have been said by why this heart failure is being seeing more common, first and foremost, aging of the population. Now the life expectancy has definitely increased. So with age, the heart failure due to your hypertensive heart disease or maybe your CAD, there is more prevalence of these diseases in our population, which is leading to heart failure. There is improved survival after MI. 20 years back, 30 years back, when all drugs and intervention was not available, the hypertensive MI-related mortality was very high. But with presence of your good PCI, good revascularization and surgical backup, we have a survival much better in MI patients. So we know the patients who have MI with LV dysfunction, they will come to us again and again with our OPDs. Plus, there is availability of the effective therapy for the prevention of sudden cardiac death in the form of AICDs, which have led to your survival in these patients, but presenting with heart failure to us. What about the Indian scenario? Can we tell the exact amount of patients which we are going to see in our OPD? There is not very clear data. We don't have, as already said, the digital data or we don't have a proper surveillance system in our setup. But estimated prevalence by different registries, by Kerala registry, by the Tamil Nadu registry, they have shown that estimated prevalence would be about 10 millions. But the second challenge between Indian population is there are limited resources. We don't have a very big resources of your heart failure clinics, pharmacotherapy, heart transplant program, resuscitation therapy. So the main therapy which remains to us is the drug therapy which we have to offer to these patients. The difference, if we see that what is the difference of your heart failure in Indian population and compared to the Western population, our patients are more younger in age. They are about compared to 10 years younger. Their ejection fraction is more lower as compared to what we see in the Western population. The mortality is very high, about 30%. And the rehospitalization rate and death post-discharge is just 4 times of what is there in the Western population. So we have to be more vigilant in these patients, and pharmacotherapy should be started in these patients in a very effective way. So because of the availability of the newer drugs in 2022, AACC came up with the guidelines for the newer therapy, and in 2021, ESC came with the guidelines, which emphasizes on the newer drugs which are available for heart failure. So they divided that, okay, heart failure, the target which I'm going to discuss in my talk will be only stage 3 heart failure. That means the patients who are symptomatic and who presented us with heart failure, how to treat these patients with the pharmacotherapy. Stage A and B, basically the predicting the heart failure or the risk of the heart failure, will not be discussed in this talk. So if we see the classification of the heart failure, what is heart failure? It's basically the patient's complaints. It's a clinical signs and symptoms diagnosis. Patient with clinical signs and symptoms of your increased swelling pressure, having breathlessness, along with we find the filling pressure in the form of your biomarkers or the echocardiography features showing that there is a patient is having an increased filling pressure, we diagnose it as heart failure. Depending on the ejection fraction, we divide into 3 categories. One is less than 40%, that is the most common heart failure with reduced ejection fraction, which we see in a population. Or it can be a preserved ejection fraction in which the ejection fraction is more than 50%. In the mid-range, we have 41, or with the mildly reduced ejection fraction, 41 to 50%. So the predominantly which we are dealing with this having high mortality is that heart failure with reduced ejection fraction, whenever the ejection fraction is less than 40%. And the drugs which have been in the past 10 years have shown that these patients should be targeted very immediately so that the mortality and morbidity can be decreased. So if we see the pharmacotherapy of the heart failure with reduced ejection fraction, what are the different goals which we have to see in these patients? Where to start? First and foremost, we have to reduce the mortality in these patients. Second is the prevention of the rehospitalization and improving the quality of the life. This should be the target for the patients who are going for the pharmacotherapy. So starting with a case example, my talk will be on the case example that how different drugs can be started in this patient. This is the normal common patient we see in our OPD. Is a 50-year-old gentleman, hypertensive, presented with class 2 to 3 dyspnea for past 6 months. And clinically, we are finding that there is increased filling pressures in the form of LVS3 is there, but chest is clear. ECG was showing poor progression of R wave, but echo was showing LV dilated with global hypokinesia of ejection fraction of 30%. And his NT-proBNP was raised. So we know that depending on seeing his clinical symptoms, his investigations, he follows the category of heart failure with reduced ejection fraction. So what are the treatment drugs which have to be targeted in this patient? So we all know this, we have learned in the MBBS time also, the neurohormonal activation is there in heart failure patients. Depending on this, we know that the sympathetic nervous system is overly active in these patients, leading to your increased epinephrine, renin-angiotensin system is activated, there is vasopressin is activated, heart rate and contractility is also increased. The renin-angiotensin system, when it is activated, it leads to vasoconstriction and blood pressure is increased, sympathetic tone and aldosterone activation is there. Plus, there is natriuretic peptide system is also elevated, leading to your natriuresis, vasopressin, and vasodilatation. So these are the therapy which we have to target in these patients of the heart failure. So if we see the different trials or different drugs which have been there for heart failure, we start with 90s. The first one was the ACE inhibitors in enalapril, which was done, and this showed a significant reduction in the mortality by 16%. There were then again, beta blocker came into the picture. It showed that additional 34% mortality was seen in these patients. Again, the ARBs were evaluated, and there was shift, evaporatin was evaluated, and mineralocorticoid receptor inhibitors evaluated. They all showed that there is 37 to 30% of mortality reduction. But the game changer came in 2014, when they said, despite all these drugs, the additional mortality benefit by ARNI is by 20%. Why this was done? Because this, if you see, the drugs that reduce mortality in heart failure, ACE and ARBs reduce mortality between 10 to 20%. Beta blockers have shown to decrease mortality by 30%, mineralocorticoids receptor by 30%. But still significant mortality happens at 5 years of age. About 50% of the patients die within 5 years of diagnosis of heart failure. So this was a game changer in 2014. A neprilysin inhibitor along with your candesartan, it was started and showed that when these patients were having your neprilysin inhibition, there was increased ANP and BNP levels, which leads to natriuresis. This was the basic mechanism of ARNI, which was stipulated. And the biggest trial which was done was Paradigm Heart Failure trial, which compared not with placebo, with other ACE inhibitor, which was a standard therapy which was prescribed in heart failure patients. And this showed that there was significant reduction in the cardiovascular death and hospitalization in these patients, which was more than 0.004. So additional mortality benefit, about 20%, was seen in these patients when they were prescribed with ARNI as compared to the ACE and ARBs. So this was the game changer. So this guidelines came with recommendation that the patients who are coming with your NYHA class 2, 3 with heart failure distraction, instead of ACE and ARB, if they are ARNI should be recommended in these because that gives an additional mortality and morbidity in these patients. So this was again after 2014, various trials were done with on ARNI, depending on the different situations. There was trials which were done on your acute decompensated heart failures. There were trials which were done on preserved ejection fraction, and the trials which showed that patients with heart failure reduce ejection fraction, irrespective of their clinical status, ARNI have shown to decrease the mortality. So this was a trial, there was like Paradigm only includes class 2, class 3 patient. What about the patient who comes to us in a MICU and have been sick in acute decompensated heart failure state, and does ARNI will helpful in this case? The Pioneer Heart Failure trial was done, but the catch was that these patients became stable, then the ARNI was started. So the thing when we have to start these ARNI, first and foremost, the systolic BP should be more than 100 in these cases. The IV diuretic dose should be stable for last 6 hours, and they should not be on inotropic support because this drug has been known to decrease the blood pressure. So once this state is reached, they become relatively stable, then the ARNI was started in these cases. And to the surprise, within 3 months of it, we can increase the clinical benefit of more than 46% reduction in the form of your death, pre-hospitalization, rehospitalization, LVAD, and transplant listing in these cases. So these patients, then again, that means the patients with acute decompensated heart failure, ARNI should be started as soon as the patient becomes stable in these cases. So this was the pioneer heart failure trial, which concluded that the drug is well tolerated despite having a low blood pressure, causing low blood pressure in that status. What about the second drug which came in after 2020 was the SGLT2 inhibitor. This started with an anti-diabetic drug, which basically was that it was a glucose receptors which are present in renal kidney, and they causes a glucosuria, thus leading to decrease in blood sugar. But various trials, when they were done, they showed that this drug also causes your decrease in cardiovascular mortality in the form of your decreased hospitalization rate and heart failure about death. So depending on this, then the trials were started on doing SGLT2 inhibitors specifically in heart failure patients. And the possible mechanism which they said that can be caused due to this is, first, there is optimized preload reduction in these cases because of the diuresis. The patient metabolism, cardiac metabolism changes in these cases, and there is decrease in interstitial edema and the improved renal function, which both led to your improvement in the heart failure, death, and hospitalization. This was the basic mechanism, but exact mechanism still not very clear that what is that which decreases the mortality in these cases is still a question of research. So 2 big trials which was conducted was the DAPA heart failure and Emperor reduced trial was done. These both were patients who were NYHA class 2 to 4, and Emperor included more sicker patients as compared to DAPA heart failure trial, and both showed that there is a significant reduction in the death and heart failure hospitalization when these patients were given with your all other 3 drugs. So depending on this, the ACC guideline came up that we have to target now 4 therapies in these cases. One is, first, your beta blockers should be given, the renin-angiotensin receptors should be given, and your NPS positive inhibitors should be given in the form of ARNI, and SGLT2 inhibitor was given in these patients. So these become like a 4-pillar therapy of heart failure to be started in these patients. The initiate, optimize, and reassess. As we were discussing also that these patients should be optimized with a maximum tolerated dose in these cases, and how frequently these to be tolerated dose should be started depends on the patient clinical situation. So this is a more a personalized medicine, rather saying that every patient will be able to tolerate a 25 milligram BD of carvedilol, which we see in our clinical practice is not possible in our settings. So what is the best time to start the therapy in these cases? First and foremost, once the patient is hospitalized, that is the best monitoring time, or whenever we come to OPD, that's the best time to start this therapy. Should we start it sequentially or should we start it simultaneously is a question. So this was the study that this shows that the planning of when these patients are admitted, if you don't start the 30% readmissions occurs within the first week of discharge, and 60% occurs within the first 2 weeks of discharge. So these therapies should be started as soon as the patient has become tolerant to these therapies. So if we see, this was a trial which was done in strong heart failure, recently published, and they said, okay, let us see, categorize these patients. One, we will start in a sequential manner once they become patient safety, and one we will start in a simultaneously, or the patients will be started. So once this was shown that within 3 months of when you see these patients, the therapy was started, within 3 months, the hospitalization rate and mortality significantly reduced in the patient in all the 4 drugs were started. So these means that the mechanism of action of all the 4 drugs is different, and these drugs should be started as soon as the patient is able to tolerate these drugs. This was and the trial was, stopped prior to it was neither at point, because within 3 months, it was showing that these patients are having a high intensity care, have a possibility of event-free survival, much significant as compared to usual case survival. So it became a class 1 recommendation to give this 4-pillar therapy in our patients who comes to us with a heart failure with reduced ejection fraction with a maximum well-tolerated dose in these cases. So coming back to our example, this patient was heart failure with reduced ejection fraction. He was started on beta blocker. ARNI was given with maximal tolerated dose with SGLT2 inhibitor, with a diuretic and a MRA, which was started in this patient. So what is the course which we can expect in these patients? There are different trajectories. Either the patient will have resolution of his symptoms. That means he will have come back with NYHA class 1. Or he may develop persistent symptom that despite all the treatment, his symptoms are becoming class 2 and class 3 and is still having the same symptom, not much benefit. Or he can be a worsening of heart failure. Despite starting the treatment, the symptoms are increasing and he is going into class 4 failure. So if the class symptoms have resolution of symptoms, we should continue with the same medications with the maximum tolerated dose of all the 4 pillars of therapy. If he is having persistent symptoms, then the diuretic dose should be increased in these patients to the maximum tolerated dose so that they can be able to do their functional capacity. But what about the worsening heart failure? That is a term which has to be very seen in these patients, because we know that the heart failure is not a course which is having us in the plateau course. If we see, once they are diagnosed, after diagnosis, they may remain stable for few months to years. So nobody can predict that till what month or what year they will be okay. But once they start having worsening, this worsening will take only a few months to develop into advanced heart failure and cardiovascular mortality. So we have to target now this worsening heart failure, these patients, and is there any other therapy which can be prescribed in these patients? So now my patient came back. Within 4 weeks, he said, I am developing increased symptoms. He was in NYHA class 4. So he came into the definition of worsening heart failure. Can we do something else in this patient? So why should we care? We know that the worsening heart failure, if we depend, 1 in 2 patients hospitalized again within 30 days of their worsening heart failure, and the mortality is very high. Despite having all the trials which have shown that we started with your ARNI, we started with your SGLT2, we started with your galactic heart failure, omeprazole, these patients have risk of developing 10 to 15% of increased risk of developing rehospitalization and cardiovascular mortality. And despite these 4 pillars, we need some additional therapy for these patients. So drug which was newer therapy, which was started, the trial was done, was a vericiguat, which gave some hope that if we start these drugs in the worsening heart failure patients, we might have a plateau course rather going for a uphill course in these cases. So basically, vericiguat has a similar SGC stimulator. The mechanism of action, it has been shown that it decreases the inflammation and fibrosis, it causes vasodilatation, and increases the renal blood flow in the patients. So this leads to your decrease afterload in these patients and decrease the LVDP. So this was the trial which was done, a Victoria trial. These patients were basically worsening heart failure patients, which were included. They were patients who have a recent hospitalization or the IV diuretic use. And if you see, these patients were on your mostly triple therapy. About 58% were already taking your ARNI, MRA, and beta blocker. At that time, when this trial was started, SGLT2 inhibitors were not still indicated. And despite that, they found that when they randomized these patients, depending on the placement, vericiguat, there was significant reduction in the cardiovascular mortality and heart failure hospitalization at the end of 2 years. So this came up with the criteria that these patients should be give advice that vericiguat can be given in these patients. So which patient should be given the vericiguat? Should we give it to all the patients coming to our OPD? Still, we do not have the data despite the known mechanism. So if the patients are who have recent hospitalization, or on one IV diuretic who have to OPD basis, or patient have a hospitalization within 3 months of your OPD basis, then these patients should be given vericiguat in the cases that can have shown to decrease your recurrent hospitalization. Only thing, when you're starting in hospital this drug, always make sure the eGFR is more than 15 ml, and patient IV diuretic should have been stopped at least 24 hours prior to the initiation of the therapy in these cases, and other quadruple therapy that the 4 pillars should not be stopped before starting this patient. Dosing is simple. It's 2.5 milligram OD for 2 weeks. If patient is able to tolerate, increase it to 5 milligram, and the target dose is 10 milligram OD. Hypotension is very rarely seen, but it is a known side effect in with this vericiguat drug. So depending on this Victoria trial, ACC/AHA came with the guideline recommendation of class 2B in patients who are worsening heart failure. Despite guideline-directed medical therapy, this should be prescribed. So coming back to my case, he was diagnosed with heart failure with reduced ejection fraction with worsening heart failure. So this all the 4 therapies plus vericiguat of 10 milligram OD in increasing dose was added and diuretic was increased. So the patient became stable and was discharged on the same therapy. So if we see in the conclusion, what are the pharmacotherapy? If we see the pillars of pharmacotherapy indication, the first and class 1 recommendation is your beta blocker, SGLT2 inhibitor, MRA, and ACE or ARNI. Prefer ARNI most probably. Then depending on the phenotype tailoring, these patients, suppose this patient's having a hypervolemia despite all these 4 drugs is not able to having still volume overload, a diuretic in the form of your furosemide group should be added in these cases. Vericiguat only if there's a worsening heart failure. Ivabradine is a drug which has been shown with a SHIFT trial that these patients who are having increased heart rate despite maximum tolerated beta blocker, they should be advised ivabradine in this shown the decreased heart failure hospitalization, but the mortality benefit was not seen in these cases. So in summary, the patient if comes to us with establish the diagnosis of heart failure with reduced ejection fraction, start the 4 pillar of therapy, not able to tolerate or still symptomatic, look for your other causes, look for if the patient is having ejection fraction less than 35% of having LF beta branch, go for device therapy in the form of CRT and ICDs, and still not able to improve, going into stage 3 or advanced heart failure, then this comes over the mechanical circulatory support or cardiac transplant, which is not the part of my topic. So how can we improve this guideline-directed medical therapy in our heart failure patients? And what can be done in settings? First and foremost, heart failure clinics are important because these patients need continuous monitoring, because we have seen if we don't give them that maximum tolerated dose in these cases, they die within 3 months. The mortality increases by 30%. These drugs are not advised. So we need good heart failure clinics and the patient education and the guiding the patient toward the best possible medical device and surgical therapy. We should have a checklist in both our wards and in OPDs that what are the treatment medicines which are being prescribed. And if not prescribed, why not prescribed? Because we always, we all are so overburdened when we write a prescription, we sometimes miss the drugs, we don't give the maximum tolerated drugs. So heart failure patients, if you know that this therapy should be given, have a checklist with us that these drugs have been prescribed to the patient. And nurses training and all that becomes a big criteria for, in these managing these patients. Have more physician education programs. And small top of the artificial intelligence, how can this help in this? Like a mobile phone based reminders. Like these patients, if we can see that these patients can send their blood pressure and their heart rate after 7 days of therapy to their concerned physician, they can easily tell, okay, now increase your dose with this. Because they cannot come up to again. And we have clearly seen in the strong heart failure trial, as soon as you increase the maximum tolerated dose, the mortality decreases. We cannot wait for 3 months, 6 months in these cases, that next time when you will come, we can increase the dose in these cases. So a follow-up reminder should be there. And telemedicine links to the primary health centers are the thing which might change the scenario of the heart failure management. So in conclusion, heart failure is a comprehensive approach. It requires both the knowledge for the pharmacotherapy. It requires knowledge backup from your surgeon. It requires good device therapies in these cases. And once in advanced heart failure, then we should have a good program for your mechanical circulatory support and the cardiac transplant team. Thank you.